Hey guys, it's Doc Hepps. So your bladder has fallen and it's not getting up. What to do? We'll give you some guidance as to how to go about this very common problem. So stay tuned. Hey guys, it's Doc Hepps. So we're going to go over bladder prolapse, the symptoms, the diagnosis, the testing that might be involved, and I'll talk about my approach in terms of a treatment plan, and then towards the end I'll go over how I do it, and hopefully this will give you some guidance and insight as to what to expect when you visit your urologist. Bladder prolapse is a very common problem. It affects many different women. It's more common in ladies who have had a hysterectomy. There's a genetic component. It's more common in ladies who are overweight or are smokers. Many different factors can influence why ladies develop prolapse, but again, it's a very common problem, and it generally can affect ladies' quality of life because they feel uncomfortable. In some situations, it can lead to urinary tract infections. It can lead to urinary retention where you can't empty your bladder properly. It also can lead, in severe cases, to where the kidneys potentially obstructed. This is quite unusual. Most ladies are simply bothered by it. It's uncomfortable. They want to know the options as to how to go about in treating it. Well, let me tell you a little bit about what is prolapse. Prolapse is basically a weakening of the pelvic floor, and this happens for different reasons, like I had mentioned, including genetics, prior surgery, childbearing, and different lifestyle factors like smoking and being overweight. What happens is muscles and ligaments of the pelvic floor that typically keep the uterus, the bladder, and the rectum supportive become weak. Either the bladder, the rectum, and the uterus in basically fall and prolapse. The symptoms of prolapse typically include a sensation of something in the vaginal tissue, a fullness, like you're sitting on something. Some ladies have urinary symptoms such as leakage or incontinence, but some don't. The diagnosis is made by exam. So if a lady comes in and they complain that I feel a fullness, a vaginal irritation, or something uncomfortable, then we do an exam, and usually that should be able to tell us whether there's any significant prolapse or not. Additional testing may include looking in the bladder or doing what's called a urodynamic study, where we would measure and assess the function of the bladder to ensure it's functioning well. Once we diagnose prolapse, what we want to figure out is what components have dropped. Like I said, it's common to see what we call a cystocele. That's bladder drop, where the bladder is bulging into the vagina. And many ladies will also have some component, what's called stress incontinence, where they leak with a cough, laugh, and sneeze associated with this. Deciding upon the type of treatment kind of depends on whether the bladder has dropped, the rectum has dropped, or the uterus is bulging as well. So some of the options that we may use and offer include doing nothing. Some ladies just are satisfied knowing that they don't have anything bad going on. There's no cancer or anything like that that's associated with this bulge sensation. And they feel like as long as it's nothing concerning and it's stable, they're just going to watch it. And that's totally reasonable for a number of women. Another option is to try and move forward with lifestyle changes, including weight loss, stopping smoking, pelvic floor physical therapy. And this can at least stabilize in many women the symptoms from getting worse. A non-invasive option is something called a pessary. This is basically a plastic circle or cylinder, and this comes in many different shapes, that's placed into the vagina, and it basically holds up the bladder.
a lady would be fitted for one that is comfortable for her, and then she would come into the office every 3 to 6 months to get it changed out. And many ladies do just fine with this who aren't interested in surgery, but they need something because their symptoms are bothersome. The last option is some sort of surgical treatment where a urologist would go in and basically lift the bladder using a variety of different techniques. One general way is to do what's called a vaginal approach, where we make a small incision in the vaginal tissues. The other way of doing surgery in general would be an abdominal approach, where typically most folks are using a laparoscopic or robotic system, where the urologist would go into the abdomen and then lift the vaginal canal and suture using a mesh implant. In that case, suture it to a sturdy area that lifts the vaginal tissue up and helps to what we call reduce or fix the prolapse. And this is a very effective way for ladies who are very active, who are younger and want to do a lot of heavy duty activities. Although it's more invasive, it tends to have less recurrence rates. So how do I do it? Well, first thing I do, if a lady comes in and she says she's feeling something funny, abnormal, a bulge sensation, it's uncomfortable to sit, we would do a history and a good exam. This exam would include a urine test and ensuring that your bladder is emptying. Oftentimes it includes a cystoscopy where we look in your bladder along with what I call a mini gynae exam to see what's going on. I might order an ultrasound to ensure that there's no abnormality of the kidneys. And then depending on your urinary symptoms, I may ask you to have what's called a urodynamic. That would help me understand the function of your bladder. Is it acting overactive, underactive? Is the muscle normal? And then once we collect that data, we would sit down and discuss the best approach for your specific situation. We talk about a vaginal surgical approach versus a robotic. Have you had a hysterectomy? Did you not have it? We'd also talk about placement of a mid-urethral sling if you were having leakage when you cough, laugh, and sneeze, versus not placing that at the time of the prolapse repair. Prior to that, obviously, we would talk about the non-invasive options, such as doing nothing, exercises, weight loss, stopping smoking. You might decide that you'd like to try a pessary prior to diving into any surgical procedures. And these would all be part of the discussion in terms of trying to improve your quality of life and finding something that works for you. So ultimately, if you did decide on surgery, typically the way I do it is I keep the patient or the overnight. Typically you have a catheter that drains your bladder, and then we would remove it the next morning. If you are urinating and you feel good, you're up and about, you get out of dock. And most ladies don't need much more than Tylenol, ibuprofen, maybe a stronger pain medicine for the first night or two. The biggest issue that I found for some ladies is avoiding constipation. For some reason, many ladies tend to have a bout with constipation, so we're very aggressive in trying to prevent that once you get home. You want to avoid any heavy lifting for at least 2 to 4 weeks, depending on what your urologist recommends. Ladies can get up, move around, go out to dinner, do sort of light duty activities, shower the next day. Hopefully it's as least invasive in your lifestyle as possible. So hopefully this gives you some guidance as to what is prolapse, how we diagnose it, how we test for it, different overview of the different treatment options, and then how I do it sort of in a brief synopsis. Thanks for watching. We'll dive deeper in some other videos, and appreciate your time.